In this chapter, we'll be dealing with maternal changes during pregnancy. So first, let us start with changes in the genital tract, so uterus. Okay, remember it as 50 grams weight uterus or 70 grams weight, it becomes 1000 grams or 1.1 kgs, okay, 1000 or 1100. So 50 to 1000. Okay, whereas the volume increases 1000 fold, weight increases 2000, volume increases to 1000 fold. So 50 grams and 5 ml here, 1000 fold, 5000 ml. Next, 7.5 is the length of the uterus, 7.5 centimeters. So just multiply, you will get 35 centimeters uterus length. Okay, and then pear shaped. Okay, so initially the uterus is pear shaped, then it becomes globular or even oval. Okay, so after that, the uterine wall at the beginning of the pregnancy, uterine wall becomes thicker, gradually it thins out. Okay, then enlargement of the uterus, it is due to interplay of hypertrophy and hyperplasia, but mainly it is hypertrophy. Just explain what is hypertrophy and hyperplasia. Hypertrophy is increase in size of the cell, hyperplasia is increase in number of cells. Okay, so mainly uterine enlargement in pregnancy is because of hypertrophy. Mechanical distension usually occurs after 12 weeks of pregnancy once the uterus starts entering into the abdomen from the pelvis. Okay, so that is there. Then arrangement of muscle fibers. You have outer layer which arches over the fundus. Okay, like this. And then middle layer, it is made up of an interlacing network of muscle fibers. Okay, so what happens is this acts as the living ligature. So after delivery, the fibers contract and constrict the perforating vessels, leading to a stoppage of bleeding. The inner layer consists of sphincteric fibers opening around the fallopian tube and the internal os. Okay. Next, Hegarstein. So there is softening of the lower uterine segment just above the cervix. So when you compress the uterine segment between the examining fingers, the walls feel very thin. So softening of lower uterine segment is Hegarstein. So 6 to 8 weeks of pregnancy. Okay. Next, position. So usually the uterus is normally anteverted and anti-flexed. Okay, but in pregnancy what happens is the uterus keeps growing in size, but on the left side you have the rectosigmoid. Okay, so that is where the uterus kind of shifts towards the right. So it is dextro-rotated. That is why you need to correct the dextro rotation while checking the fundal height. Okay, next, uterine blood vessels. So basically arteries, they undergo hypertrophy, increase in size, veins also increase in size, lymphatics also they increase and multiply, increase in size and multiply. Okay, everything increases. Then uteroplacental blood flow. Basically there is an increase in blood supply to the placenta which is brought by the spiral arterioles. So what happens is initially you have trophoblastic invasion of the spiral arteries. Okay, so the invasion of the trophoblast, it destroys the muscle walls as well as the elastic layer of the spiral arterioles so that they become non-sensitive to the pressure reagents. Lots of hormonal changes take place during pregnancy. So you don't want the spiral arterioles to respond to each and every single hormone. So that is why this invasion takes place so that the elastic layer and the muscular layer of the spiral arteriolar wall is destroyed. Okay, so trophoblastic invasion occurs in 3 stages. So pre-invasive, once it invades, so it is within the wall, so intraluminal, wall and the lumen, and then wall replacement. Okay, so first pre-invasive, intraluminal and wall replacement. Pre-invasive phase is up to 12 weeks. So trophoblasts invade the endothelium of the spiral arteries. Okay, during the intraluminal stage, so 12 to 20 weeks, the myometrial spiral arteriolar wall is invaded by the trophoblast. Okay, so this myometrial arteriolar wall, the spiral arteriolar wall, is replaced by fibrinoid material. Okay, so that is why they dilate and act as a reservoir when the uterine blood flow is increased. Then uterine contractility. You have something called Braxton Hicks contractions from early pregnancy, which are painless, irregular and intermittent. Irregular, intermittent, painless. Okay, they occur at long intervals, last for a shorter period. Okay, up to 15 to 25 mm of Hg pressure. Okay, so again in the later stages of pregnancy, they may cause some discomfort leading to false labor pains. Next, then they later become at term regular, coordinated, frequent, last longer and all that. So they transition into true labor pains. Cervix. So cervix becomes soft and blue. Okay, from the first trimester onwards. Why does it become blue? Because of increased vascularity and edema, along with hyperplasia and hypertrophy of the cervical glands. Because of hyperplasia and hypertrophy of the cervical glands, there is an eversion of the endocervical columnar epithelium, which appears as erosion in pregnancy. So this is soft, velvety and red, and when you take a pap smear, it may bleed. Secretion. So there is bloody show. So basically you have a mucus plug which closes off the cervical canal, but it is dislodged at the onset of labor, so you'll have a bloody show. Okay, so that is what is there. Next, the cervix also, it loosens, the collagen content decreases, and there's an increase in water content. So this causes softening and ripening of the cervix at term. The fallopian tube is also stretched out and it is more vascular. Round ligaments are thickened and hypertrophied. There is no ovulation during pregnancy, so the corpus luteum, the ovaries are enlarged, especially the one containing the corpus luteum. Okay, then vagina. So you have something called Chadwick's sign. Okay, so there is a bluish or violet discoloration during pregnancy, and the vascularity also increases. Secretion. Okay, again, in what happens is you have lactobacilli. So they, because of increased glucose, they kind of consume it, increased glycogen. So increased metabolism of the lactobacilli, increased lactic acid, so the pH decreases. Okay, because the pH decreases, you have other pathogenic bacteria, their growth is inhibited. Okay, next, changes in the breasts. So breast changes, what happens? So in basically majority of the changes, they occur at 2 periods: second month, fifth month. So second month, the breasts increase in size and sensitivity, and you also have venous engorgement, so you'll have blue streaks appearing like this, especially at the periphery. The nipple becomes more erect and the areola is more deeply pigmented. Okay, and then you have Montgomery's tuber follicles or Montgomery's tubercles. They're hypertrophic sebaceous glands. Okay, these all occur in the second month. In the fifth month, what happens is a less deeply pigmented areola forms around the primary areola. This is called secondary areola with secondary Montgomery's tubercles. So areola, nipple erection, venous streaks, all these, and increase in size, etc. You can see in the second month. And again in the fifth month, you can see secondary areola, secondary Montgomery's tubercles. Okay, again you can see colostrum, which is the first breast milk. Next, hematological changes during pregnancy. So this is something you need to remember. See, blood volume, see, plasma volume increases by 40% and RBC volume increases only by 20%. So relatively there is hemodilution and physiological anemia because of this. Okay, also maternal erythropoietin level increases because kidney function increases in pregnancy. You need to remember this. Okay, number of RBCs also they increase. So RBC volume increases, RBC number increases, plasma volume increases more than that, so you will have hemodilution. See, HP mass increases, but HP concentration decreases because of plasma dilution. And next, plasma protein increases, but the concentration decreases again. See, AG ratio is normally 1.7:1, but in pregnancy it is 1:1. That is, globulin is increasing, albumin is decreasing. Okay, so that is one thing you need to remember. Next, WBC, the total count, it increases. Okay, and neutrophils and lymphocytes, they increase, especially if you do a DLC. Okay, and see, platelets usually they are normal, or otherwise in very few people they decrease. Okay, why do they decrease? Because it could be due to benign gestational thrombocytopenia or hemodilution, and because of splenomegaly. Okay, next, pregnancy is an immunocompromised state. Why do you say that? Because you are shifting from TH1 to TH2 in pregnancy. Okay, this is not seen in pregnancy induced hypertension, but in rest of pregnant women normally you see TH1 shift to TH2. Okay, so that is why humoral immunity increases, TH2 increases. So correspondingly, cell mediated TH1 immunity decreases. And see, TH1 decreases, so IL-1, 6, TNF alpha, all of these, they decrease. So that is why diseases mediated by TH1, they improve in pregnancy. So what do you have? Hashimoto's, multiple sclerosis, rheumatoid arthritis, etc. Because TH2 is increasing. IL-4, 10 and 13 are increasing. So that is why diseases mediated by TH2, they flare during pregnancy. All the inflammatory markers increase, all the clotting factors except 11 and 12 increase, and that is why pregnancy is a hypercoagulable state. Okay, 11 and 13, sorry, they decrease. And again, serum fibrinogen level increases, but one thing you need to remember is fibrinolytic activity will decrease because tissue plasminogen activator is more. Okay, so tissue plasminogen activator, what is there? The inhibitor is more in pregnancy. Okay, and also there is splenomegaly in pregnancy. So that is one thing you need to remember. So total blood volume increases mostly because of plasma more than RBC. So there is hemodilution, that is physiological anemia of pregnancy, but it is never less than 11 gram per deciliter. Okay. So again, pregnancy-induced hypervolemia, it meets the demands of the enlarged uterus, okay, and also it protects the fetus from the impaired venous return effects and all that, and it also safeguards the mother from adverse effects of blood loss during delivery. Okay, all of this, then change in all this we've discussed, and blood, all these 11 and 13, except them, all the other clotting factors will increase. Okay, clotting time and bleeding time are unchanged in normal pregnancy. Then AG ratio, we talked about this. So plasma proteins will increase, but the concentration will decrease. So albumin decreases, globulin increases, normal ratio becomes 1:1. Okay, so serum electrolytes. Remember that sodium levels, potassium levels, okay, calcium levels, bicarbonate levels, okay, Na plus, Ka plus, Ca plus 2, HCO3 minus, all of them fall in early pregnancy. Early pregnancy, all fall. But Cl minus, there is no change. Alpha fetoprotein, okay, that also it will be elevated, especially in case you need it to diagnose neural tube defects and omphalocele. Okay, lipids also, the total serum lipids, triglycerides, cholesterol, phospholipids, everything rises during pregnancy. Then metabolic changes. So what all do you have? Weight changes during pregnancy. See, you can remember it like this. See, in pregnancy, the weight gained is normally up to, remember, like 11 to 12.5 kgs, but the net weight gained is 6 to 6.5 kgs. 6 2s are 12, okay? So factors affecting the weight gain include pre-pregnancy weight, socioeconomic status, parity, ethnicity, all this, but smoking does not affect the maternal weight gain in pregnancy. So especially if it is a thin woman, you recommend a weight gain of additional 6 kgs, so 12 plus 6, 12 to 18 kgs. But obese woman, then your recommended weight gain is less than 7 kg. So 6, 12, 18, something like that. See, you need an extra of 350 kcal per day in pregnancy, especially in second and third trimester. In first trimester, no additional calories are required. But in lactation, double of 350 or double of 300. So you need 600 kcal per day. Okay. Amount of water retained in pregnancy is around 6.5 liters. Everything is around 6 when you talk about weight. Okay, so that is why a woman gains around 12 kgs, right? So 5 kgs in second trimester, another 5 kgs in third trimester, something like that. Low weight gain is associated with preterm or low birth weight infants. Next, excessive weight gain, you can have preeclampsia and GDM. Next, water metabolism. So again, retained water is 6.5 liters. So out of this, 3.5 liters is a water content of fetus and placenta and amniotic fluid. And 3 liters is accumulated due to an increase in the maternal blood volume and uterine size. Okay. After that, source of water. So fetus, placenta, amniotic fluid 3.5. Increase in maternal blood volume is 3 liters, and increase in venous pressure due to occlusion, that is 1 liter. But you'll not count that. Next, carbohydrate metabolism. See, usually pregnancy is a hyperglycemic state. Okay, this because you need to supply glucose and glycogenic precursors to the fetus as well as to the mother for additional fuel. So you two metabolic phases in pregnancy. First, you have early pregnancy, you'll have anabolic phase. So energy is stored, okay? In late pregnancy, you have the catabolic phase. So fetus competes with the mother for circulating glucose. So insulin resistance is there in late pregnancy. So fasting blood sugar value is lower in pregnancy than it is in the non-pregnant state, because pregnancy, it represents an accelerated starvation stage. So the human placental lactogen, the HPL, it promotes, like, see, HPL tells you to be like PL, people, okay? So it tells you to be like all those models, etc. So what do models do? They lose weight. So lipolysis. And again, they don't take sugar. So they don't want extra glucose. So gluconeogenesis is also prevented. It causes lipolysis, prevents gluconeogenesis. Okay, so that is why pregnancy, it represents an accelerated starvation stage. So lipolysis is promoted. So this antagonizes, HPL also antagonizes insulin action in the periphery. It allows glucose to be available to the fetus. Next, you also have insulinase, okay, which kind of starts degrading the action of insulin. So that also contributes to diabetogenic state of pregnancy. To compensate for anti-insulin state because of insulinase, the insulin secretion is also increased in pregnancy. Then basal concentration of insulin is normal in first and second trimesters, but it increases in third trimester. Next, fat metabolism. See, in pregnancy, the storage of fat increases, okay? The levels of cholesterol, phospholipid, free fatty acids, everything increase, okay? They decrease with breastfeeding. So again, because of accelerated starvation state, you can have ketonuria, ketonemia, especially in hyperemesis gravidarum, starvation or uncontrolled DM. Starvation ketoacidosis, diabetic ketoacidosis, like that, hyperemesis. Next, protein metabolism. See, total protein, plasma proteins are increasing, but the concentration is decreasing. So the fetus and placenta contain approximately 500 grams. 500 grams is added to the uterus as contractile protein and to the blood as hemoglobin and plasma proteins. Mineral metabolism. So copper and ceruloplasmin levels increase in the plasma. Okay. Next, iron metabolism. So iron, folic acid, vitamin B, all of them decrease in pregnancy. Next, cardiovascular system. See, the diaphragm is elevated by the enlarging uterus. So the heart also, it shifts like this upwards. So the apex goes more outwards, and it shifts from left fifth intercostal space to left fourth intercostal space. This gives a false impression of cardiac enlargement. Okay, with the slight hypertrophy of the left ventricle due to the cardiac overload, because of the increased blood volume, the left ventricular mass and diastolic pressures are increased. So left heart, everything increases. Heart sounds, you'll have a loud S1, unchanged A2 and P2 components of S2. S3 also you will hear in most women. You'll have systolic ejection murmurs, and also you'll have a peaked prominent S1 in prominent S in lead 1 and inverted P wave in lead 3. So S1 pin 3. Okay, I like to remember it like this in pregnancy. Next, pulse rate also, it increases by 10 beats per minute. So cardiac output, it increases in first and second trimester, and there's a slight decrease in third trimester. At the time of labor, the cardiac output further increases to 15% of what it is, and 50% in the second stage of labor. 15% increase in cardiac output in first stage of labor, 50% in second stage of labor. Further increase is seen soon after delivery, because you need, because a lot of blood may be lost and you still need to compensate for that. Okay, and also because the compression on the IVC is relieved after that, and the venous return increases. And next, so cardiac output in pregnancy. See, pre-pregnancy 4.5 liters. So 12 to 16 weeks 5.5. Mid-pregnancy to 32 weeks 6. Then again it reduces to 5.5. So first trimester increase, second trimester increase, third trimester decrease. Okay, so BP again, it kind of is normal only. Then you can have varicose veins as well in pregnancy. Then you'll have something called supine hypotension syndrome. So because when the patient lies supine, when the woman lies supine, then the gravid uterus, it compresses the IVC, and then the venous return decreases, causing this syndrome. Then this can be avoided by asking the woman to lie on the left lateral side. Next, respiratory system. So the lower lips, they kind of flare out because the diaphragm is going upwards and all that. So that is why the subcostal angle, it increases, okay, because the lower lips are going out. Then the level of the diaphragm is raised by about 4 centimeters. Transverse diameter increases by 2 centimeters, okay. Then respiration is more diaphragmatic than costal. Next, what happens is, see, as the diaphragm goes up, the total lung, the diaphragm goes up, the lungs are getting compressed, so the total lung capacity decreases. So if you consider this, tidal volume increases, but IRV is the same, but still IC increases, inspiratory capacity increases. ERV and RV both decrease, so functional residual capacity decreases. Okay, then there's an increased awareness of a desire to breathe even in early pregnancy. This is because, see, progesterone has a direct action on the respiratory center. Okay, what happens is, let us see here. See, in pregnant females, what happens is the functional residual capacity, we said it was decreasing. So that is why there's an increased amount of air which is still being trapped in the lungs. It is not going out. The CO2 is not going out. So because of that, there is a respiratory CO2 is in the lungs. Okay, it is not in the blood. So again, because blood CO2 is decreasing, blood acid is decreasing because of lung problem, there is respiratory alkalosis. So that is why the kidney will do compensatory metabolic acidosis. It will excrete away HCO3 minus. Okay, because of this excreted HCO3 minus, what happens is, because of decreased bicarbonate, oxygen binding capacity of the blood will increase by Bohr effect. Okay, so blood oxygen carrying capacity increases, oxygen consumption increases, and also because of increased tidal volume, you'll have more oxygen coming into the lungs. Okay, then GIT. See, what happens is, you need to remember that pregnancy is progesterone is a smooth muscle relaxant. It relaxes the lower esophageal sphincter. You'll have gastric increase in gastric reflux during pregnancy. Then gallbladder motility is decreased. It antagonizes the activity of cholecystokinin, progesterone. So that is why you'll have a gallbladder stasis, gallstones maybe. And then GI motility is normal in antenatal woman, but it is decreased in labor. Okay, that is something you need to remember, because when you are giving anesthesia during labor, because of decreased gastric motility, you can have some aspiration also. Okay, so this is these are the things you need to remember. Next, changes in the kidneys. So basically, kidney size is increased. Kidney size is increased. Dilatation of the renal pelvis. Even the ureter increases in length and in size. Okay, in early changes, the ureteric length increase and size increase results from lack of tone of the smooth muscles of ureter because of progesterone. Okay, because it relaxes smooth muscles. In later months, this can be because of compression of the ureters by the enlarging uterus, especially on the right side. So yeah, because of dextral rotation, so that is why you can have right hydroureter as well. This can predispose to urinary tract infection. Okay, so that is why you can see all this urinary stasis, intravesical pressure increases. Okay, and then so basically in pregnancy, what you can see is because of large volume, because of hemodilution, plasma volume increases, all that, there is an increase in renal blood flow, increased GFR. So there is increased filtrating capacity of the kidney. So there is increased excretion of urea, uric acid and creatinine. So all these are decreased in the blood. Okay, again, so antibiotics for UTI, so you can use nitrofurantoin 100 mg BID, 100 mg BD for 3 days or 100 mg for 10 days. Okay, so basically glycosuria is common during pregnancy, but it is not necessarily pathological. Okay, you need to think of the possibility of diabetes as well. Bladder, remember it like everything increases. So trigone increases, it enlarges, it goes upwards. Okay, there is widening and deepening of the tribone. The base of the bladder is pushed forward and upward, and especially because the fetus keeps compressing on the bladder, so you'll have increased frequency of micturition. So nervous system, so you can have temperamental changes like psychosis, melancholia, depression, so postpartum blues, all that, especially due to lack of sleep. Next, endocrine system. So you have the placenta, which secretes a variety of hormones. So starting with HCG. So HCG is secreted by the syncytial trophoblast. It's a glycoprotein with highest carbohydrate content in the body. So it is the glycoprotein with the highest carb content. So it has two subunits, alpha and beta. So the alpha subunit, it resembles FSH, TSH, LH, all this. Okay, and then so basically the levels are increased if it is a twin pregnancy or a molar pregnancy or choriocarcinoma, and levels are increased even in Down syndrome. It is decreased in to threat. Okay, there's a threat to HCG to decrease. Two, so ectopic pregnancy and threat, so threat and abortion. So functions, it maintains the corpus luteum till about the 68th day. I like to remember it as 69, so 68th day, when the placenta takes over and corpus luteum is no longer necessary. It also stimulates fetal testicular testosterone to promote male sex differentiation, and also it stimulates the maternal thyroid gland. So in women, especially when there is increased HCG, so hyperthyroidism may develop. Then estrogen. So remember that pregnancy is a hyperestrogenic state which lasts till delivery. So again, in the non-pregnant woman, estradiol is most important, and pregnancy, estriol is quantitatively more. So estriol is largely derived from DHEA. Okay, near term, the fetus is the source of 90% of all of the estriol. Maternal pituitary has little or no influence on estrogen synthesis in pregnancy. So that is why when there is anencephaly and all that, the formation of placental estrogen is severely diminished, especially in anencephaly and fetal death. So basically this is how the estrogen synthesis takes place. Not only estrogen, other hormones. So you have maternal blood going to the placenta, then to the fetus, fetal blood, and then fetal adrenal cortex. See, everywhere you will have cholesterol, okay, going in. See, but in the maternal blood you need progesterone and estrogen. So from the placenta you will have progesterone, but from the fetal adrenal cortex only you will get DHEA. Okay, that is why fetus is responsible for 90% of the estriol precursors. That is why when there is fetal demise or anencephaly, you will find decrease in estrogen. So DHEA, again, it goes till here. It is converted by the placenta to estrogen. Then estrogen goes to the maternal blood. Okay. Then progesterone. It is a hormone that sustains pregnancy. So during early weeks of pregnancy, the luteal source, corpus luteum, is vital for the sustenance of the conceptus, after which the placenta takes over. Okay, usually around the 60th day. So biosynthesis complex, again we talked about this. So pregnant from progesterone is excreted in the maternal urine as pregnant diol. Okay, after that, see, basically it causes smooth muscle relaxation, it stimulates the respiratory center. Okay, and it also causes growth of the alveolar system. See, the duct system, it is stimulated by estrogen in the breast. Okay, then nipples, areola, pigmentation, duct system, all of this by the duct system is by estrogen. Okay, development of alveoli and the lobules along with the growth and pigmentation of the nipples and areola is by progesterone. Pigmentation, progesterone. Alveoli, progesterone. Duct system, estrogen. Okay, so these are the functions of progesterone in pregnancy. Then androgens, so basically androgens increase but the binding proteins increase more, so that is why free circulating androgens are less in pregnancy. Next, HPL. So it was also known as HCS, so human chorionic somatotropin. It is also produced by the syncytial trophoblast. So basically, it from a very low level in early pregnancy, it keeps on rising till term. Okay. Next, so HPL, it is most produced. HPL is most produced hormone at term than other hormones. So it causes lipolysis and inhibits gluconeogenesis. So it leads to an increase in maternal levels of insulin. Okay, this will have an anabolic effect. Then prostaglandins. So prostaglandins, again, you have them widely distributed everywhere in the body, but mostly in the endometrium, deciduum, all this. So PGF2 and PGF. And so this is they contribute to expulsion of fetus. Next, you have changes in endocrine glands. So basically, the pituitary gland, the size and weight increases by 125%, especially anterior pituitary. So after delivery, if there is PPH, it will lead to anterior pituitary necrosis known as Sheehan syndrome. So basically, you will have growth hormone, prolactin, ACTH, oxytocin, everything being increased, but FSH, LH are decreased. Okay, so that is one thing you need to remember. So MSH also increases, so this causes pigmentation changes in the body. So vasopressin, most important is antidiuretic activity. So you retain water because of that in pregnancy. So you have all these other hormones. So thyroid hormones also, because of hyperplasia and increased vascularity of the gland, and also because of globulins are increasing, so thyroxine binding globulin. So because of that you may have hyperthyroidism, and after that insulin and all this. So pelvis, basically what happens is, because of the enlargement, you need the joints to sort of become lax, the sacroiliac joints, the pubic joints, sacrococcygeal joints, etc. So mobility also needs to increase. So that is why, because of especially effect of progesterone, the pelvic ligaments become lax due to the effect of hormones. Okay, and the pregnant woman has severe pain in the joints, difficulty in walking. So that is why, because of the increasing shift of increasing weight and the shift of gravity downwards, there is lumbar lordosis, and also the neck also is flexed and slumping on the shoulder girdle. There could be compression of the ulnar and median nerves. Okay, and skin abdominal wall. So you can have diastasis recti. So rectus muscles may separate in the midline. Okay, so you can have striae gravidarum or stretch marks. You can have linea albicans also. Okay, and you can have linea nigra and colasma or mask of pregnancy. You can have because of hyperestrogenism, spider nevi, palmar erythema, etc.